I'm Amita Gupta. I'm at Johns Hopkins University, and I will give you a few slides, but I'm more interested actually in having a conversation. So I won't dwell too much on slides, and then we have Audrey Becker. Would you like to introduce yourself?
Hi everyone, I'm from Cape Town. I'm a neonatologist with Stellenbosch University and I'm privileged to be here.
So I think all of you are interested, or at least are expressed an interest in pregnancy and infant health, so congratulations. We're very happy to have a continued larger family interested in this issue. Out of curiosity, how many of you take care of pregnant women or children in your TB practice or work? Excellent, all right, great. So you're really the experts. What we're going to do is go through a few key points, and feel free to interrupt. Just raise your hand, ask us to stop if you have a question or a comment or an example to share. So what I'm going to do is, as I said, I'm going to use just a couple slides. I won't necessarily go through the entire deck. We have some slide presentations, and then we'll leave the rest of the time really for interaction, discussion, cases, policy issues, research gaps, things that you feel are critical for us to think about as we move forward in the field. So to start out with, I don't have any disclosures. I'll go through some epidemiology, impact on maternal health outcomes, some of the issues for screening and treatment. So I'll start out with a couple of case presentations, and just to kind of give you a breadth of the spectrum of some of the things you might see in pregnancy and postpartum. So this is a case from my colleague Shilpa Naik, who's an obstetrician in India, and she had to handle a 26-year-old woman who was 10 weeks gestational age, who presented with vaginal bleeding and abdominal pain. And she had just recently been diagnosed with pulmonary TB when she was 6 weeks pregnant. It was a smear-positive case, and now the woman unfortunately has an ultrasound showing that the pregnancy has had failure of the pregnancy. So certainly early in pregnancy diagnosis of TB can be a stress on the body and lead to gestational failure. And this is a case report that was published a few years back. Here, the issue was there was a Ghanaian pregnant woman with gestational diabetes, and there's sort of questions remain about how much of a risk is gestational diabetes. We certainly are learning a lot about diabetes and TB, and there's negative synergistic sort of problem that they cause for where diabetes is a risk factor for developing TB for more severe presentation. So she had 4 months of cough, and unfortunately, her cough was kind of minimized in terms of the workup, and they did not actually do a chest x-ray, partly because they were fearful of radiation exposure during pregnancy. And unfortunately, I'll show you some data from Radiological Institute where really a chest x-ray, particularly if it's shielded, really poses no risk. The amount of radiation from a chest x-ray is less than 5 picograms of radiation exposure, which is completely safe and never been shown to impact the fetus. So she ended up having a delayed diagnosis and ended up having disseminated TB disease, and it impacted her eyesight, causing optic atrophy, chorioretinitis, and uveitis. And furthermore, often what ends up happening with these cases, she had to have her neonate separated from herself because she was still infectious, and they ended up having to do formula feeding, and baby got prophylaxed. So unfortunately, delay in diagnosis, disseminated disease, and separation from her newborn, which all can be quite traumatic and stressful. This case, just published this month in the Emerging Infectious Diseases, is the first published case report of using bedaquiline in pregnancy. There was a 33-year-old woman who developed MDR-TB in the Republic of Georgia. She relapsed subsequently and then eventually developed XDR-TB. And she did not complete her treatment. She had one of those wonderful complex regimens, not very well tolerated, that involved cycloserine, perthanamide, clarithrol, clofaz, capryomycin, et cetera. And she actually became treatment, so she defaulted, became pregnant, and during her pregnancy then sought care in France at 30 weeks of gestation. And in France, they saw that she had a cavitary lung lesion but her fetus appeared normal on ultrasound. She then, see if I can forward this. Sorry. Okay, there we go. So they did a resistance DST, and she had evidence of susceptibility to cycloserine PAS, bedaquiline, and linezolid. And so they ended up at 36 weeks of pregnancy, putting her on a regimen containing linezolid and bedaquiline. And they also put her on PAS, cycloserine, and levofloxacin. And at 39 weeks, she delivered a full-term baby. There was no evidence of TB on the placenta. Her infant was negative by gastric washings, and because she was still smear positive, her infant had to be separated after delivery as well. So in this case, they followed the baby and mom for 2 years after and reported that the baby seemed to have a normal growth and there was no other evidence of abnormalities. Now, mind you, short amount of exposure in pregnancy from 36 weeks to 39 weeks, and by that time really this is well outside of a critical formation period of the fetus, but at least this is the one case report. And I know in South Africa they have additional cases where they've been using bedaquiline in pregnancy. They just haven't been published. So it's FDA category B, which means that at least from the animal data, there isn't any major adverse sequelae that have been observed. Yeah. They actually had no real data. They didn't do a lot. They didn't say whether I don't think she breastfed. She was in France, and they hadn't advocated for that at any point. But the case report doesn't have a lot of details. Any other questions about any of those three cases? Are these rings sort of? Yes, Simon.
I'm surprised that all the babies are removed from the mothers. That we actually give prophylaxis to both susceptible and drug-resistant cases. The only ones that are separated are the XDR cases where you don't have any option for prophylaxis. Because separating the mother is a risk both to the mother, well, basically to the baby, because you're not breastfeeding, and that is a risk in itself.
Yeah, so Simon, you bring up an excellent point. So back in the 1950s, or it might have been in 1949, 1951, there was actually a Lancet series of women and their children in Durban who'd been hospitalized, and they saw the negative impact of separating the baby from mom in terms of it's bread and butter maternal child health, right? It really is better for the baby to be with mom and to be breastfed whenever possible. Interestingly enough, you know, we have these cases and people get so excited in the United States. We had a case of a woman who was MDR in pregnancy, and the amount of resources and sort of discussion over whether or not to separate baby from mom while she was still smear positive. They felt very strongly that the baby had to be separated, and we tried to make the argument that we didn't feel that that was appropriate with the appropriate mass. So I'd be welcome, like you really see a lot of these cases, as does Audrey, and you know, your perspective of that you're able to basically manage these children, moms and babies, with good outcomes when they are kept together. So you want to speak more to that, or sort of how do you address the concerns or fears? Will you address that, Audrey?
I'll first speak about drug sensitive, and then Prof can speak about drug resistant. So for drug sensitive mums, what we tend to do, especially if it's low birth weight babies that are admitted to our neonatal wards, we're obviously very careful with regards to infection control for the other babies and mums on the ward. So if the mums are still smear sputum positive, we actually give them a period of 2 weeks on treatment. But during that time, we encourage the mum to express breast milk so that we can still continue breastfeeding in the baby. And then once she's at year end, after 2 weeks, we actually allow her and baby to be together, and then prophylaxing the baby and asking the mum to wear a mask. And if Prof want to add anything to that.
So as far as the drug-resistant cases are concerned, if they are still susceptible to the fluoroquinolones, we actually give ciprofloxacin. And the reason why we give ciprofloxacin is because we don't have a suspension in any of the other drugs. And hopefully soon we will have levofloxacin in dispersible tablets, which one then could give to the infants, because that would definitely be better. And then we combine it with high-dose ionization ethionamide, because one of the two would most likely work depending on the mutation, the ionization mutation conferring resistance. And then, of course, when they go home, it's preferably that they sleep in separate rooms from the mother until she's non-infectious, and whenever the mother breastfeeds, she needs to wear a mask. So that is the advice that we would give. And we follow up the babies very carefully. And I can't remember that we had any case developing tuberculosis if the baby was on preventive therapy.
Anybody else have any experiences to share that where separation occurred or why it happened, or positive experiences where you kept mom and baby together?
The guys in Mexico advised to separate the baby from the mother until the mother is negative. The breastfeed is extracted with a pump, so the milk is given by the grandmother, but once the conversion to negative, we allow to.
I would say that's how most expert consensus guidelines are, although in some scenarios they really sort of feel, at least in high-income settings, formula feed. They don't even sort of necessarily recommend the breast milk. But of course, in many settings where we recognize the importance of breastfeeding, most of the drugs, for example, do not cross into breast milk in any significant concentration based on the available data that we have. Certainly INH, rifampin, the few drugs that have been studied do not appear to have much penetration into the breast milk compartment. So it's certainly safe to express that milk and provide it to the baby. And then you heard about the use of expanded prophylaxis. If the mom is susceptible to fluoroquinolones, they've used ethionamide, fluoroquinolone, and high-dose INH preventive therapy prophylaxis to the baby. So that's South Africa is using that prophylaxis regimen. Other places have used levofloxacin or ciprofloxacin, as you mentioned, because that's what's available in suspension. And you'll hear more from Audrey, I think, on some of the other cases. So this, I think, we certainly don't have, and I think I'll get to this point, but I can bring it up now. I mean, one of the challenges about managing pregnancy and infants is that these populations are not included in any of our clinical trials. So you're left with individual case reports, case series, expert opinion, and you look at the guidelines, and often you'll have some conflict. One, WHO might have one, your National Ministry of Health guideline might say another, CDC might say another. So part of that is really because of really lack of evidence that's specific to these populations. And so some of the work we're doing, and I'll mention some of the studies that are ongoing, we're trying to collect better data. Audrey has been working in this with Simone and others. Jyoti Matad here is working on looking at, for example, INH, rifapentine, the 12 doses in pregnancy, so we can do some actual data evidence base for pregnant women and their infants. But certainly, we have no PK data for any of the second-line drugs in pregnancy so far. Okay, so I'm just going to give a couple of quick points. I won't go through all this, but the burden of TB in pregnancy. So no national database actually collects whether or not a TB case, the person's pregnant when they report their TB case data. So we're left with sort of estimates. We do know that certainly TB peaks during reproductive age, whether you have HIV or not in high burden settings. And we, as shown here, sub-Saharan African women, and we don't have data that's really based on national reporting, but so we have individual screening studies. And the range for active TB, higher in HIV positive, 1% in low burden Crohn's, but these are really old data, many of them pre-ARV era. That number has gone lower. And on high burden settings, it depends on whether the screening was done only among those who were latently infected, TST positive. Then you get numbers such as high as 11%. But if you look across all the studies that have been done on TB screening in pregnancy, in sub-Saharan Africa and elsewhere, it's about 2% of pregnant women with HIV have evidence of active tuberculosis if screening is done systematically. and sometimes as high as 3%. And then with latent TB infection, depending on the test, whether you use TST or quantiferon, you have a range, and it's higher in HIV-infected women living in high-burden settings to as high as half the pregnant women being latently infected, and much lower rates in low-burden settings depending on the populations that are being screened. So overall, we estimate at least 216,000 cases of TB occur in pregnancy based on this estimate done by Sugarman and colleagues a few years back, most of which are in high-burden settings. And I think I'm going to just summarize some of the things we've noted from the literature. Most of this literature is case series or case control studies where they've looked at impact on pregnancy and maternal complications. So twofold increase of preeclampsia, twofold increase of vaginal bleeding, hospitalization significantly more prevalent, miscarriage, tenfold increase, increased maternal mortality, and here are some of the references. For infant fetal death increased, more likely to be low birth weight, prematurity is increased twofold, small for gestational age, increased perinatal death. Rarely do we observe congenital TB. It's a difficult diagnosis to make, but there's been about 300 case reports since the beginning of time when we reported in the medical literature. And in the pre-ART era, evidence of increased HIV transmission when mom had TB with HIV compared to just HIV alone. So the other question comes up, does pregnancy as a condition increase your risk of acquiring a TB or reactivating or the severity of illness? And you know, there are biological reasons to think that pregnancy may alter the immunology. Certainly we know rheumatoid arthritis improves, multiple sclerosis actually can often have exacerbations. We know flu and malaria and other diseases can be impacted during pregnancy as being more severe. And so and I just summarized these here in this. This is this lovely clicker. I love this clicker. I've been watching, sitting here when I had to moderate, that all my speakers had problems with the clicker. All right, I should have removed all of, sorry. All right, well, in any case, if I can get this to move forward, maybe you can try, I'll keep talking. Okay, thanks. Give that back to me. All right, so, can't trust her. All right, so as I said, these are all, oh dear, okay. Let's just move, if I can just get over these slides. All right, well, I'm not going to even worry about the slides. So the subsequent points are the following. So with respect to immunology, we certainly are studying immune changes of pregnancy. We have cohorts in India where we're serially actually taking women with LTBI infection with and without HIV, longitudinally following. Jyoti Matad here is, and Malika Alexander and Shilpa Naik and our team in India are working on sort of basically looking at observations. You can move it to the next slide. Great, and so some of these observations, biologically, we understand their immune changes, actually have been observed epidemiologically. So here's a very large UK primary care cohort where they looked at almost 200,000 women, and they had 264,000 pregnancies. They observed an increased rate, almost twofold, of TB occurring in the first 90 days postpartum, suggesting that the relative immune suppression of pregnancy and the rebound in the immune system that occurs postpartum may be sort of unmasking the sort of control of latent TB infection or acquisition of TB in pregnancy. Obviously, these are women who are in UK, so there's not a lot of community-based transmission happening. So most of this is probably reactivation occurring in the early postpartum. So certainly observed epidemiologically and needs to be better understood immunologically. In terms of the screening, certainly there seems to be that pregnancy might be associated with less sensitivity of both our TB symptom screen as well as diagnostic sort of yield. So here are a few studies from high burden settings, 80% sort of being where they can screen positive from the WHO symptom screen, and the relative yield of smear. Less, if you look on the left of that, 54%, 43%, 28%. These are studies done in South Africa, Kenya, India, where the symptom screen was less sensitive at being able to detect TB in pregnancy. So some suggestion that both because there might be more extrapulmonary TB, but also less obvious symptoms that you can capture from your symptom screening in pregnancy. These are relatively small studies, but at least give us some hint that there may be a difference in how well these screening tests work. For latent TB screening, basically we have, the goal is to, if you're going to test somebody, you want to treat them for LTBI. There's actually not that much data specific to pregnant women and screening for LTBI in pregnancy. The US studies show some differences between high burden settings. So actually, in the US settings, the 2 or 3 studies that have been done have shown that the IGRA is less often positive compared to the TST, whereas in high burden settings, the opposite's true. We find more IGRA positivity than TST positivity in pregnancy. And then there's been data to show that a positive IGRA is predictive of postpartum tuberculosis. Here, these are some of our data from India, where we looked at different stages of pregnancy using TST in the blue bars, and the green bars were the quantiferon test. And as you can see, depending on which test you used, you got a different result for TB infection positivity. So much more likely to be reported as being positive by quantiferon than by TST, irrespective of which stage, and especially in the postpartum period, where almost half the women were positive by the quantiferon compared to the delivery or antepartum, which was 30% or so. So that gets at, it does actually matter which test to use. If you're doing if you are using LTBI testing as part of your screening to triage LTBI prophylaxis. And then I made this point about, you can keep going forward. So here, if you look at for chest x-ray, and this is really important, if you ever get asked whether it's safe to do a chest x-ray for screening in pregnancy, if you have a shielded chest x-ray, it's not a concern. So do not let that be a barrier to not having a woman get screened for TB during pregnancy. And it's all there. The chest x-rays at the very bottom, minimal, less than 5 rads exposure, not associated. You can give them this reference. And also the American Obstetrics and Gynecology also backs that up. So please, please, please don't let the x-ray be in the way. All right, so I'm just going to say a couple things about treatment. You can go to the next slide. So I think if some of you attended Paolo Denti's talk on PK, there are certainly major changes physiologically that happen in pregnancy that can impact metabolism, absorption, drug disposition, and they include increased body fat, body weight, decreased albumin, and alteration of the hepatic metabolizing enzymes, particularly the cytochrome 3A4 and other cytochromes that can potentially impact drug levels. Next slide. Yes, so you can skip over that and I'll go through. These are sort of the FDA categories, and most categories are just animal studies demonstrate risk. So if you look at the first line drugs, INH has been around for decades. Almost all of them, INH, rifampin, and PZA, are still category C, because they've not, again, really been well studied. There's the sort of data from the animal models, and we've studied them in non-pregnant populations, but we're left with still categorizing them as, the benefits may outweigh the risks, but we don't have a lot of human data that under careful scrutiny. Next slide. So there's a study done in South Africa where actually they showed that women who were both on INH and efavirenz, there were some decreases during pregnancy in efavirenz exposures. So pregnancy was associated with decreased efavirenz. It's also subsequently been associated with modest increases in rifampin because of decreased clearance, but that are not clinically meaningful. So far we don't need to do any dose changes for rifampin. With INH, there's some data that just came out and were presented this summer at IAS that suggests that there are lower concentrations in pregnancy of INH, but again, the clinical significance of that remains unknown. They've just looked at 12 women and did PK studies in pregnancy and found lower levels, so we're waiting to see if that actually ends up being relevant for our clinical practice. And these are summarized here where the rifampin clearance and the INH exposure reduction. Next slide. So we have a debate. The WHO recommends a 6-month regimen, irrespective if you're pregnant or not. The CDC guidelines basically recommends omission of PZA, particularly if you're HIV uninfected and are not a high risk, and can tolerate 9 months of treatment. So that is actually still being used. So in the US, many women who do get diagnosed with TB during pregnancy end up with 9 months of treatment because the CDC guidelines talk about not using PZA. And yet the WHO recommends using it. So if you live in India or South Africa or Kenya, Mali, you will get 6 months. If you live in the US, there'll be discussion at the health department level of whether or not to use PZA, and it's a lot of fun. I'm like, well, look, most of the TB is global. Most of the women globally receive 6 months. Why are we having to extend therapy in the United States? I already made the point about breastfeeding, so it's not an issue. Generally, and we talked about expressing breast milk, and here's the categorization. It's really the main issues of aminoglycosides are category D, so they're to be avoided, except for capreomycin has been used. There are case reports of it being used in pregnancy, and all of these other drugs have little to no data specific to pregnancy, and I presented the bedaquiline. So let's just okay, and then here, there's a bunch of case series. We have about 60 published case reports of MDR-TB in pregnancy with variable outcomes. The largest is from Peru with the case series that were published a few years ago in CID. And they're mostly using personalized regimen. Many of them deferred the use of aminoglycoside till after delivery and tried to come up with the best second-line treatment that they could come up with. So if you're interested, this is summarized in a CID paper by Jyoti Mathad and colleagues. All right, so I'm going to just say a couple words. I won't show any more slides. So a couple of words about treatment of LTBI. So we have a trial where we're looking at INH antepartum versus postponing it to postpartum in HIV-infected pregnant women. We'll have results looking at that because of this question of INH hepatotoxicity in pregnancy. We had designed a study just to see when is the best timing for women to get INH. And we'll have results. Our goal was to show that you can safely provide both INH and antiretroviral therapy in pregnancy. So stay tuned. We'll have those results probably by February of next year. We cannot yet use the INH rifapentine short course regimen because the TBTC26 trial did not include pregnant women, so we have no safety or PK data. Impact P2001 is ongoing right now, where they are specifically giving the 12 doses of INH rifapentine, doing a PK safety data, and it's halfway enrolled, and they basically will sort of inform whether or not we can safely use INH rifapentine during pregnancy. So that is encouraging that we'll have some data for how to manage latent TB infection in pregnancy in high burden and low burden settings. And then lastly, I just wanted to put a plug in for the need to, I think, advocate for clinical trial involvement, for engagement, inclusion of pregnant women. We've done a really good job for HIV and antiretrovirals, in part because we were so focused on transmission reduction. So we've learned a ton about antiretrovirals in pregnancy, but if you look at tuberculosis, we have really no data. And so what I would like to, and we've actually been with TAG, some of my colleagues, Lindsay, from the Treatment Action Group have been phenomenal about really pushing that needle to getting more engagement of clinical trialists doing TB studies to try to get women who are pregnant included, and certainly also children. So I'm going to stop there and let my colleague, Audrey, take over from the infant angle. Any questions? Yes.
Thank you. I was just wondering, as per IGRA in pregnancy, in children, the discordance is not that much. TST performs as well as IGRA in high-burden countries, particularly if they have micronutrient deficiencies. Is there any reason why in pregnancy IGRA is performing better than TST?
So, you want to answer that? We don't know why. We're looking into why. You know, it's interesting because some of it is, there are other studies in non-pregnant populations where IGRA is more likely to be positive, particularly in high-burden settings. And the question is whether that reflects recent exposure better than, so in the US, for example, where we have a higher proportion being PPD positive in pregnancy than IGRA, most of these women have been in the US for a long period of time, have not had any recent exposure. So that's one reason that possibly IGRA may be more of a readout for recent exposure. But it also could be, and so I would say that we don't have as much, we don't have a biological reason yet as to why that is. Do you want to comment, Lisa? You've looked at IGRA and TST in children, as have you. Do you have anything to say about that?
It just really is like the more complex, immune response that is required for a PPD, right? And so there's just a more kind of involvement of the entire immune system. And so my hypothesis is it's, different cells involved and that you're able to kind of capture that. But definitely in youngest children, if a kid's under 5, I actually end up doing both tests because you can really increase your sensitivity. So you definitely have discordance between those two tests. So in the meantime, clinically, I just do both in populations where I have suspicion that they're not going to perform well. But
I'm going to try and manage the mic and the clicker. We'll see how it goes.
You want me to?
I think I'm going to be okay. So just moving a little bit to the infants, and I've broadly divided the talk into 3 things. First of all, I want to show you of perinatal TB, its clinical presentation, and some treatment options that are available. And then I would lastly like to share with you the approach that we are using at Stellenbosch University in Cape Town on how we manage a TB-exposed newborn. And there's not a lot of evidence for this, I realize that, and most of it is actually based on years of experience and guidance from people treating and managing these infants. And I would love to hear from the audience what they are doing when they have a situation like this. So first of all, we were confronted a couple of years ago with a baby that was delivered in a peripheral hospital, a 38-week-old male weighing 2.6 grams, and he had severe respiratory distress and abdominal distension. The mum was 18 years old. It was an uncomplicated pregnancy, and she was actually HIV negative. At delivery, the baby was in terrible distress and had to be intubated and transferred to Tygerberg Hospital, which is a tertiary care hospital in Cape Town. And in managing this patient, it's obvious from the picture that there was a lot of edema, pale, petechial rash was present, there was a large liver and spleen. The radiology showed bilateral infiltrates in the lungs, and you can also appreciate a lot of acidic fluid in the large liver on the abdominal X-ray. And the ultrasound also confirmed some hyperechogenic lesions. So we basically knew we were dealing with a congenital infection, but the problem was what were we seeing? And as neonatologists, we went through all the steps of looking for toxoplasmosis, rubella, CMV, herpes. We even checked for parvo. But even in our setting in Cape Town with a high burden of TB, no one actually thought, can this be congenital TB? So it took quite long for the penny actually to drop for us to start thinking about TB. And the first thing we did, which I hope every clinician would do, is we started with a good history. So we asked the mum, was she coughing during pregnancy? Did she have any night sweats? Was she aware of any fever? Was there any apparent weight loss? And she answered no to all of these questions. She also didn't know anyone else with TB, but because of the high TB incidence in our setting, and she couldn't produce sputum, we actually went ahead and we did an X-ray. And this is what we found. A mum with miliary TB, completely asymptomatic, giving birth to a baby with congenital TB. So when we actually started looking, we found TB everywhere. The mum had an endometrium biopsy that grew TB. From the baby, we actually grew it from the tracheal aspirate, the urine, the acidic fluid, the bone marrow. Just showing if you have a baby like this with overwhelming disease, it's very important to actually send off special investigations and try and see if you can get the bug and see what you're dealing with. This baby was quite difficult to treat because we couldn't give the normal treatment that we would to any child with TB because this baby could not tolerate any feeds for months and months. So we actually had to switch to the IV options that were available in South Africa, and those were very limited. So in consultation with infectious diseases, we started the baby on IV rifampicin. We only had IV ciprofloxacin available, even though that's not so ideal, and IV amikacin. And as we could, we started introducing oral isoniazid, and as the baby improved, we slowly transitioned to the oral drugs. And this is the story of the baby. So after a year in hospital, on oxygen, for a very long time, he actually did well. And the only problem that he currently has is he's actually wearing hearing aids, which is probably due to the long-term amikacin that we had to give to him. So just looking a little bit about perinatal TB, and that's basically a term that's used to combine congenital TB and postnatal TB, acknowledging that there's a lot of overlap between these conditions when you look at them clinically. So as Amita's already mentioned, congenital TB is very rare, and that was the first case that I ever saw in my life. And the transmission is normally in utero by hematogenous spread via the umbilical vein, but it can also be via ingestion or aspiration of the amniotic fluid during birth. The postnatal infection is way more common. So this is where you have a mum coughing, breastfeeding her baby, and that close contact with the baby often spreads the bacilli, and the baby inhales it and then develops TB. But independent of whether you're dealing with congenital TB or postnatal TB, so the combined group of perinatal TB, your approach to this is actually the same, and your management of the patient is the same. Just one slide to link a little bit to maternal TB. We do know that if a mum has primary TB or disseminated TB, her chances, because she's got the bacillemic phase, to transmit in utero is much higher. So that's often linked to the congenital TB. And mums with pulmonary TB are most likely to transmit postnatally to her baby when breastfeeding her baby. So when should we consider TB in neonates? So this is quite difficult. It's not the typical pattern that everyone is used to. And I think the important thing is if you have a baby in a high burden setting that's not responding to your common treatment, you have to have a high index of suspicion. And there's certain things that can guide you along the way. This is a review that Prof. Scarf and myself did, where we actually looked at 75 cases in the literature of congenital TB, and we tried to see what are the common symptoms and signs that can guide you that this is actually what you're dealing with. And what came up often in all the different case reports were either respiratory distress, hepatosplenomegaly, and of course, if you were premature and low birth weight, you had a high risk. And we've already heard from Amita that if the mum has TB in pregnancy, she's twice as likely to have a premature or a low birth weight baby. Just looking at the chest X-ray features, and this is now comparing the purely congenital TB cases with the ones that developed a little bit later. Miliary TB was more common in the neonate, so less than 28 days of life. And the older the infant gets, the more it started looking like infant TB, where you have your typical enlarged lymph nodes with the bell valve effect and the obstruction picture that you're all very familiar with. Just with regards to treatment, you would treat a baby the same way that you would treat a child. The same drugs will be used. And depending on different protocols, people suggest 3 drugs or 4 drugs in the intensive phase. Perhaps just to mention, we are very cautious of using ethambutol in our setting, and the reason for that is the side effect of the optic neuritis. So we often tend to rather give ethionamide as a fourth drug if we decide to give a fourth drug. And the advantage of ethionamide is that it crosses the blood-brain barrier better. So if you have a case with TB meningitis, it may actually be a better treatment option. Then with regards to dosing, we've heard a lot about pharmacokinetics at this talk already, but dosing may be different in the very small babies compared to children, compared to adults. So where we know children in general have an increased clearance and often need higher doses of a drug, a small baby doesn't necessarily metabolize and clear a drug that easily, which may mean that the same milligram per kilogram can actually give you very high doses in a baby. And one needs to be cognizant of this when you decide what dosing you are going to be using. So in 2010, when the WHO recommended the higher dosing strategies, INH of 7 to 15 milligrams per kilogram, we decided to see what is actually happening in the babies, the low birth weight babies, so less than 2,500 grams, that we are giving IPT to. So what levels of INH were we actually achieving? And we decided to use the lower end of the dosing range, so we used 10 milligrams per kilogram, and we also looked at the genotyping of these infants. And this is what we found. So the concentrations are on the x-axis and the sampling times on the, that's the y, and on the x-axis. And what we're aiming for is that red block. So we wanted to be above 3 at 2 hours of time for the Cmax, between 3 and 5. And what we noticed was that all 20 children easily achieved those targets, but they even actually achieved much higher levels. So the safety work that we did in conjunction didn't give us any signals, but just for people to be aware that if you have a very small baby, you may need to be cautious when you use the high dose of a dosing range. We also look at the NAT2 genotyping. They didn't do this yet previously in very small infants, and we actually saw that there was already a difference at birth, distinguishing slow and intermediate and fast acetylators from one another. So just in conclusion, when we were dosing at 10 milligrams per kilogram, we actually easily obtained target plasma concentrations, if not even higher, and the reduced clearance was shown in the slow acetylators. Yeah, so to move on to how do we approach a TB-exposed newborn in our setting. So you can have one of a couple of scenarios. You can either have a mum that may pose an infectious TB risk to the baby, and I'm going to define now by what I mean when I say that. Then you can have a TB mum that is non-infectious, and of course you can have a well baby or you can have an unwell baby. So in our setting, the definition we use to decide whether a mum potentially poses an infection risk to the baby or not is we actually use whether she's recently been diagnosed with TB, because we know if she has not received treatment for a long time, the baby is probably unprotected. And what we use as a definition is if she's received less than 2 months of TB treatment at the time of delivery, we will consider her as having a potential risk to the baby. Alternatively, a mum that has either stopped with the treatment or still sputum positive, because obviously she will also still have a risk for the baby. So just going back to the possible scenarios that you can be confronted with as a clinician. And I've divided it up, and I'm going to talk you through each one of them. So first of all, you can be in a setting where you have a mum, she's been diagnosed early with TB in pregnancy, she's taking her treatment, she's sputum converted, the baby is born doing beautifully, and in a setting like that, we would choose to only observe the baby and very carefully do follow up. So in this kind of scenario, we would not necessarily give any prevention or treatment, but we would do regular follow-up of the baby and ask for TB symptoms at each visit. Then going on to the second scenario that you may be confronted with, and this is now on the background of a mum with TB. If the baby is unwell, it doesn't really matter if you think the mum's TB is under control or not. That is then a baby that you need to screen for TB. And what we use in our setting when we screen for TB is we normally do 2 gastric aspirates, we do an expert in culture, and we also do chest radiology. Depending on the clinical picture of the baby, we will do further investigations if indicated, but we do not routinely do abdominal ultrasounds on all of these babies or lumbar punctures, only if the clinical picture guides us towards that. And then looking at the well baby now, but the mum has been diagnosed with TB 3 days prior to delivery of the baby. So this baby is at high risk of contracting TB or having contracted TB. So these kind of babies, we would also screen for TB. So if you look at scenarios 2 and 3, and we do this TB screening with whatever we define it is, we need to decide, are we now dealing with no TB or are we dealing with TB? So if we think we're not dealing with TB and we decide we're going to give prophylaxis to this baby, we don't actually give BCG at birth, and the reason for that is the potential inactivation once you start with the INH. We give INH for 10 milligrams per kilogram per day for a period of 6 months. And I think a key message is when you follow up these babies, remember they gain weight very, very rapidly and they outgrow their INH dose. So it's extremely important when you see them in your clinic to weigh them and to adjust the INH dose appropriately, not to risk underdosing them. And then of course, if there's any clinical worry about the baby, you would screen the baby for TB. And then TB treatment, we've already discussed. And then I'm going to open the floor to questions. And I would love to hear what other people are doing in the same settings. So, yeah, please. Oh, there.
So lovely talk, Audrey. Thanks so much for your perspective. It's just incredibly valuable. One question I had, so I had a very interesting case of a congenital TB, child with congenital TB, who had no symptoms at all, right? And the only way we discovered it was by doing an ultrasound that had some abnormalities and eventually showed that it was a very clear hepatic adenoma, right? So I was just curious, in the unwell babies as well as the well babies that have a high risk, why not just do that as a simple screen? Because, that's one of the main modes of acquisition. And essentially, you can really have those without any clinical symptoms or abnormal LFTs,
So basically, whether to do the ultrasound or not routinely because you've been caught where you found a well baby with
Yes.
ultrasound.
I think that depends on the setting where you're in and what resources you have available. So in our setting, it's actually quite difficult to get an abdominal ultrasound. So we really have to have a good reason. It really depends on the income of the country, I think, that you're actually staying in. But if there's any concern, we will be able to get it. But to convince the radiologist to do one on a well baby, even if, in your case, you actually picked it up, is very difficult. I must just say, a couple of years ago, we did routinely do abdominal ultrasounds in all these babies, and they did the same in Durban, but the yield was extremely low, and that's part of the reason why it's fallen away.
Thank you. Hi, Mark Tabri from Evelina Children's Hospital in London. It's a very different setting. Thank you very much for 2 fantastic talks. Now, I was wondering, the notable absence from the tests you're doing postpartum, whether that's in a well child or unwell child, is the absence of immunological tests. So you're not doing TSTs or IGRAs on these children? Is that, bearing in mind that probably the performance will be suboptimal. I take that point.
Well, fortunately, we don't see many cases of congenital perinatal TB, first of all. The ones that we did, we have actually done IGRAs on, but unfortunately, all of those were more or less negative. So we didn't really have a good yield. We don't routinely, in the very small ones, do the PPD because we expect them to be negative. But in this specific case that I presented, we actually did both, and both were negative.
So great talk, thank you. Maybe a comment. Oh, Vanessa Rose from Haiti. I thought it was very interesting, your comment about the mother being asymptomatic on her symptom screen. And maybe if you wanted to comment on an approach, as we've been discussing, about screening people that are not reporting symptoms, where you have either a suspicion of TB, either the child being sick and you're wondering where did the child acquire this TB, or in the context of contact tracing, because there are no clear recommendations, and some people shy away from routinely investigating people in a closed setting where there's active TB because they're not reporting symptoms. That's very common in Haiti. We actually do systematic chest x-ray and for HIV-infected people, whether or not they report symptoms, and up to 30% will have an abnormal chest x-ray and they're fine and have active TB.
So I think you raised an excellent point, and actually in places where, so Chris Hoffman and other colleagues in South Africa have done screening, sort of systematic screening, including in pregnancy, and have found, between 2 and 5% of asymptomatic tuberculosis. And so what I would say to that is that if you're in the right epidemiology, high-risk setting, certainly if a woman's been exposed or lives in a high transmission area, and you are in a clinic where you're seeing, more than expected, I think there's increasing awareness of the whole spectrum of TB, and it's really probably only time that at some point she would become symptomatic. So in some scenarios, screening asymptomatic individuals certainly makes sense. In a place like where we've done our screening in India, where we routinely screened everybody, and these are data from our OB and team with Jyoti and Catherine and others, where we did not find, because we have a large proportion of HIV uninfected, we did not find any asymptomatic TB in the 700 women that we screened or so. So it really comes down to knowing your incidence and your epidemiology, and certainly getting data locally for where you're practicing, where there might be certainly benefit among HIV-infected pregnant women. And mentioned that 2%, if you look at all the studies, I didn't show the slide, but between 2 to 3% of those systematically screened actually have TB, and as you mentioned, anywhere from 5 to 30% are asymptomatic, or don't have the 4 WHO TB symptom screen. And the other piece to know is that lymph node TB can be more prevalent. So, and relatively asymptomatic, other than having lymphadenite, a lymph node that's enlarged. So that's important to note as well. But in places where, you could do, if in a low income, in a high income, low burden setting, there's, not a lot of yield for doing TB screening unless you're sort of with a large foreign-born population, recent immigrants, et cetera. So it really is the epidemiology that would help you.
Yes, and that's, I wanted to give you some experiences from our setting in Sweden, Stockholm. I'm Judith Buchwald from the Karolinska Institute, infectious disease physician, and we've actually screened pregnant women from high TB endemic countries since January 2016, and about 3,000, we target women from high incidence countries, and they are screened at the first visit during the pregnancy, and then we found out of 3,000 women screened, about 300 were quantiferin positive, and in those we found, I think, 6 cases with asymptomatic TB or very few symptoms, and several of them also had negative chest x-rays but had positive MTB cultures from sputum, so we found them very early. And it is very rewarding if we look at it's a cost-effective intervention.
That's fantastic. So that's important data. So I think, again, like looking at where your risk groups are, we don't like to sort of necessarily do risk groups. So in the U.S. setting, still a lot of antenatal clinics are still doing PPD or IGRAS as part of their routine screening, even though there isn't necessarily clear guidelines about doing that, but it certainly has, as you've mentioned, in certain places where there's large foreign-born recent immigrants, does yield where systematic screening is worthwhile. Others that might have things to share about experiences?
Please, Lucia, Mexico. I would like to say something about the newborn. When you are working out sepsis, you have to work so quickly, so rapid, to say there is no sepsis and to look for tuberculosis as soon as you can. And the suspicion is higher, you can start with medication because they can die in 2 or 3 weeks. So, and also they have sometimes skin lesion, skin damage, and you can take the biopsy of that tissue and can give you more for diagnosis.
Thank you. I think it's a very important point that in neonates they deteriorate very quickly and very rapidly. So it's associated with high morbidity and mortality. So you should not wait, that's true. But my plea is before you start the medication, try and send off as much samples as you can, that you can actually have the information on whether you're doing the correct thing and how you want to manage the baby going forward.
Thanks again for bringing the topic of maternal and child TB to the conference. I think you might have covered this earlier. The best treatment and safest treatment for an MDR TB patient early on in her pregnancy, first trimester, and very ill. The 5 drugs that you might choose for the mother, and the drugs you might choose for close household contacts who are very young. And thirdly, should there be a big concern for congenital TB if the severity of illness at this stage of pregnancy is quite severe?
So I would use, we would want 5 active drugs. I would try to avoid the aminoglycoside, especially if she wants to keep her pregnancy. You'd have to, it's a complex discussion around, the keeping the baby. I certainly, there's data to show that you certainly can continue the pregnancy. So things like PAS, ethionamide, fluoroquinolone if you have relatively low susceptibilities. PZA, in some places there's too high of a community background rate of resistance, but you could use that. And then if you have access they have used cycloserine in pregnancy as well. So that we sort of look at what you have access to, and as long as you have what you know in your community in terms of the MDR TB treatment, you would try to do essentially a similar regimen except for the aminoglycoside. That's the main thing that, especially early on, because there is concern for, in first trimester of actually causing permanent hearing loss. So, and very careful monitoring. In a lot of instances, women with counseling choose to also terminate their pregnancy because they're so fearful of what all of these medications end up doing to the baby in the absence of a lot of data. So we always counsel, whatever's going to make the most sense for that woman and her decision around, what she wants to do. Others that might want to say what kind of regimens you might choose in terms of 5 active drugs, and have many of you used aminoglycosides in first trimester pregnant women?
The only other point I would make is that if you look at the literature or have other colleagues that have tried to treat women with MDR-TB, if you pick an effective regimen, many of them do very well. So it's just a matter of getting the right drugs, like Amita said, and pick the 5 drugs. But you shouldn't be more nervous about it than you necessarily would be otherwise. They seem to have good outcomes, and their infants also. 38 or 43 or something.
Exact number. They followed their enrollment in developed MDR-TB in pregnancy group, and they used a variety of regimens. They were personalized based on whatever information and access to drugs they had. And there they had success at least 60% of the time. There was variable initiation during the course of pregnancy. A few of them were in the end of their first trimester. So you can look at that case series. That's the best, actually, the largest case series that exists for managing MDR-TB in pregnancy. So, yeah. And we're about to wrap up, so one last question.
Yes. Nosotros, en Spanish, nosotros tenemos TB en gestantes y hacemos el mismo esquema, damos tratamiento tanto para MDR como TB sensible durante la gestación.
They have pregnant with multi-drug resistant, and they use the same treatment. So, do you take care with the aminoglycosides?
Nosotros usamos 6 drogas. Amikacin, levofloxacin, etionamid, ciclocerin, and piracinamide and etambutol. Y al nacimiento hacemos el descarte tal cual han mencionado ustedes.
At the delivery, they use to do what you recommended today with the newborn. What else?
Una pregunta, aprovechando. ¿Ustedes han llegado alguna vez a hacer biopsia hepática en un recién nacido?
Do you have any experience with biopsy, liver biopsy? Liver biopsy? Yeah? Yeah. Oh, no, in the newborn. Yeah. That's it.
No, we actually don't recommend doing that. If you look at the traditional congenital TB classifications, the Beinske and the Cantal, they do describe it in the Beinske, but that was mainly on post-mortem when they actually got those findings. So we would just use ultrasound if you're suspicious, and if you see a lesion there, you would treat, but I don't think we would recommend to do a biopsy.
And I think the point that, sorry, I didn't catch your name, a clinician from Peru, has used aminoglycosides in pregnancy, and including in that Sonia Chin case series, there were women who did receive aminoglycosides in pregnancy. So it's not that you can never use it. I mean, sometimes when you only have, if you have pre-XDR or even XDR, you're sort of limited in what you can do in terms of the number of agents. I think this is a push where we want to get compassionate use to things like delamanid and bedaquiline for such cases. And as I mentioned, we have at least a few cases from South Africa where they're using bedaquiline in pregnancy because of pre-XDR, XDR, or the case report that I provided to try to avoid the aminoglycoside use. But certainly there are treating clinicians that have used it, and not all of the children develop hearing loss in follow-up. So I think ultimately you're left with your best epidemiological data you know about MDR, XDR, TB in your area. You won't necessarily have all of the information when you're trying to decide empirically what to start a pregnant woman on. It's going to obviously require a lot of conversation, both about what we do and don't know about the drugs, but we're trying to obviously really get her treated with the best regimen that we can and what you have access to. But I also would encourage you to apply for compassionate use for the new drugs. I haven't heard, I know I spoke to the Otsuka folks, they have had women who've become pregnant on delamanid, but I'm not aware of anyone who's actually received delamanid for compassionate use for their MDR, XDR, TB in pregnancy. So if any of you have had any experience, let me know.
Hello, I'm Nathalie Leschnal from MSF, and I'm working with the NTB project. And as you know, we treat MDR, XDR, mostly pre-XDR, apparently, from the current results. And so some of the women in our cohort are getting pregnant. We follow drug-exposed pregnancy, so usually we don't start them in the NTB cohort if they are already pregnant. But most of them, they get pregnant on treatment, so we design a regimen for them, and then they get pregnant. And from the early results analysis we presented yesterday, so in most of those women, we are able to maintain the regimen as it was designed initially. I think mostly because we are lacking of options, but meaning they receive bedaquiline and delamanid in combination. so during the pregnancy, and so we still need to have a look at the outcomes, of course. Most of the women, they decide to interrupt the pregnancies currently. I think they are very aware about having MDR, XDR and treatment for 24 months with the baby is not the best. But some of them are keeping the baby. Currently, we only had very few miscarriages. I think 2 patients. One patient lost the baby afterwards, and seeing at this presentation, I think we should have been more suspicious of the transmission of TB in the baby, because he got a fever and then he died from aspiration. It was not that clear because obviously we're not in the ground, so just getting the information through reporters. So I think we should investigate more on this baby. But yeah, overall, most of the pregnant patients that are XDR, pre-XDR, we don't have the choice, so we just maintain the regimen that they have. And if they want to keep the pregnancy, we follow them up as best as we can.
Women continued their pregnancy on the regimen. Do you have any estimate of?
Yeah, I can find the number. I don't have the number.
Just curious. It'll be very instructive as we're learning more and more about the new drugs. Well, I think Audrey and I would agree this has been a wonderful interactive session, and we really appreciate all your comments. And we look forward to all of you contributing to increasing the knowledge and awareness and the sort of what we can learn from the experiences we all have, and hope to have better guidelines rather than case series and expert evidence to help us move the field forward. So thank you. And Audrey, do you want to say?
No, thank you very much for coming.